Perfect.
Fabulous.
Okay, welcome everyone to University of Colorado Ethics Grand Rounds. And we are glad to have you join us today. I want to introduce myself first. I am Julie Swaney. I am one of the co-chairs of the University of Colorado Hospital Ethics Committee and on the Ethics Grand Rounds Planning Committee with my colleague here, Dr. Jackie Glover. And we're really very pleased to introduce Dr. Chris Knoepke. And Dr. Knoepke is going to speak with us today about red flag laws and the Colorado Clinician, and particularly the ethical dimensions of all of that. I want to remind all of you, please put your questions and your comments in the chat, and Dr. Glover and I will be monitoring the chat, and we'll be able to ask your questions or give your comments to Dr. Knoepke at the end of his talk. So this is, by the way, the last Ethics Grand Round sessions of this academic year. We will be off July and August, but then we'll be back in September. So watch for that mailing as well. So it is really my honor to introduce Dr. Knoepke. Dr. Knoepke is an assistant professor in the Department of Medicine and in the Division of Cardiology, and also is on the Leadership Council of the Firearm Injury Prevention Initiative at the University of Colorado School of Medicine. So Dr. Knoepke, thank you very much, and I will turn this over to you.
Thank you very much. And I want to thank everybody here for the opportunity to come and speak. I think this is a pertinent and timely topic, and it's exciting to be able to meet many of you and to see those of you who I've known, through previous work, both in cardiology and related to firearms. I want to also introduce or help, reintroduce, I guess, the Firearm Injury Prevention Initiative, which is a brand new initiative here on campus led by Dr. Emmy Betts, who I'm sure many of you know, alongside Joe Simonetti, Aaron Kelly, and others, as well as, those of us on the Leadership Council include myself, Eric Siegel, Steve Berkowitz, Catherine Villopoulos, I think I mispronounced her name, but many of you might know her from surgery, and Dr. Ian Stanley. Where we are, we're sort of still formulating ourselves, but we're interested in a public health approach to firearm injury prevention in all of its forms. We're nonpartisan, of course, and we advocate for the best science and education around firearm injury prevention. And so what I'm here to talk about today obviously has some local pertinence, but there's a nationwide kind of scale to it. I think that there's a lot of questions that we are trying to hopefully answer adequately, but also sort of keep the discussion going, because very few of these issues are kind of resolved either from a scientific or from an ethical standpoint. So just moving on from there, my normal disclosures, nothing particularly sort of exciting here, other than, a number of grants that I have. I have a K-23 from the National Heart, Lung, and Blood Institute, an American Heart Association Career Development Award, and then a bunch of project support grants. There's no conflicts, no off-label use, anything like that. The only reason I highlighted the Fund for a Safer Future is that they're funding some of my current work with the Colorado Office of the Attorney General to create improved training materials for law enforcement officers regarding red flag laws or extreme risk protection orders. You'll hear me use the terms red flag laws or ERPOs, which stands for extreme risk protection orders. I'll probably go over that a few more times just to keep it clear. That's why I highlighted the FSF there. The rest of the disclosure, which I think is important, is to be fully transparent. I'm not an ethicist, and if I were to spend several years developing another professional skill set, I might choose ethics, but it bears noting that I haven't done so. So I might not adequately address ethical tensions, questions, or models, but I welcome discussion from those of you who are more knowledgeable in those areas. I'm also not a lawyer. Any of the statements I make sit on sound legal ground, but some of the issues haven't been tested in court yet. But just know that I'm not an attorney. None of this should be understood to be coming from an attorney or anything like that. Just as importantly, I'm not a technical expert on guns. I grew up in a home with firearms and I shoot targets on occasion, but I'm no technical expert at all. I personally find that, you can't name all the parts of guns, so your opinions are uninformed arguments, kind of pedantic attempts to skirt real dialogue, but it bears noting that I'm not a technical expert when it comes to firearms and their parts. It also bears noting that I am a licensed clinical social worker, and before coming to CU, I worked in a variety of outpatient behavioral health settings, including employee assistance programs, community practice, substance misuse prevention, things like that. I've had clients at risk of suicide who I supported using the legal and professional tools available at the time. I understand the tensions that are at play when you're having these conversations, both for professionals employed by big systems like UC Health, or for those who just hung a shingle in the community, either on their own or with 2 or 3 clinical practice partners. Moreover, I understand the state of training of the behavioral health workforce with respect to firearm suicide prevention and otherwise, which is honestly to say that unless you've had some very specific mentorship in those areas, your training was probably not great. I'm also familiar with the disclosure process that you engage in when you begin to work with a client as a social worker, psychologist, counselor, somebody like that, which is honestly a bit more involved than it is for physicians or those in the in the medical side of things. When you're talking to someone who's engaging in even a few sessions of psychotherapy, you tell them about the limits of confidentiality, like mandatory reporting concerns about child abuse, abuse of older adults or other people who might be vulnerable, and you tell them about duty to warn, duty to protect, things like that. Which when I was working clinically, I always dealt with head on by telling people that reporting was part of my job, but one that I didn't particularly relish, and that I would talk to them and involve them as much as possible if I was going to make a report. And I kept my word. There are 3 different states in which I made mandatory hotline call, contacts reports with the person who I was reporting on speakerphone there with me, making it a sort of active, engaged process. And I have to say, I'm not sure how I would go about that now that red flag laws are on the table here in Colorado from a clinician standpoint. And finally, I understand that everyone, or I assume that everyone, healthcare and behavioral health professionals, gun owners, law enforcement, public health advocates, and anyone else who's involved want to do the right thing when someone's at risk of violence, either against themselves or against someone else. Violence, including suicide, is multifactorial in every single circumstance, which lends to a variety of quote unquote right answers when it comes to the combination of interventions or treatments which are necessary or would be helpful in terms of preventing them. So all that out of the way. Let's talk about gun violence in sort of the broad sense. We know some of the top line statistics, particularly about the United States. Almost 50,000 people a year are killed, and many more times that injured by firearms in the US each year, and that number continues to rise. The popular pictures of gun violence are the ones that most people are most scared of. Mass shootings, especially public mass shootings, about which we're painfully familiar here in Colorado, obviously, dominate the way in which a lot of people, including health and mental health professionals, approach gun violence. I think this makes sense because mass shootings have the highest emotional valence. They're scary and they feel unpredictable, but they're far from the whole story of who dies by gunshot, which is actually much more broadly represented by people who die by suicide and a smaller number of homicides. Most of homicides occur within conflicts between people who know each other. So intimate partner violence, conflict within families, workplaces, etc., are a major contributor to the proportion of gun deaths that are homicide. But again, the main driver of gun deaths is actually suicide. Nationally, about 60% of gun deaths are self-inflicted, and that proportion is actually higher here in Colorado. And more to the point, I think that it's more likely that a clinician is going to encounter a patient who is at risk of suicide than they are somebody who's reporting that they're going to enact violence against somebody else. And even if they are encountering somebody who is threatening violence against somebody else, they are in all probability also threatening violence against themselves. So you'll hear me talk about suicide specifically at several points, and that's purposeful because I think that's the most likely and common scenario. If you work in clinical practice long enough, you're going to have clients or patients with risk. So here's what we came to see, right? Aggressive iconography and all, but I want to frame this within the greater context of violence and suicide prevention with patients so that we can meaningfully engage with the ethical issues at play. So just to get some terminology down, red flag laws, which are otherwise known as gun violence restraining orders or GVROs in California. In Illinois, they're called firearm restraining orders or FROs, but most commonly across the United States, they're called ERPOs or extreme risk protection orders. So every town here has a nice little map. It's incomplete actually because it doesn't include Wisconsin, which recently enacted their very brand new ERPO law statute system. Michigan just enacted theirs not long ago as well, but the other 19 plus the District of Columbia have relatively more long-term established systems. And by long-term, I mean, going back to 2019 for 2020 for Colorado, 2016 for California. Every other one except for Indiana and Connecticut came after that. But we'll get into that a little bit more. But these laws are civil restraining orders, which except in Connecticut and Indiana where they're warrant-based orders, which allow petitioners, so the people who can send the petitions, to request an emergency court hearing that would prohibit a person who's called a respondent with imminent risk of harm herself or others from possessing or purchasing firearms. So it prevents people from legally possessing or purchasing firearms. That's the thing to remember. Despite the seemingly sensitive political nature, national surveys consistently illustrate greater than 85% approval for these kind of risk-based approaches, including the greater than 75% support among firearm owners. Why they have this high level of support is sort of an open question, but my guess is that they feel kind of unobtrusive to the vast majority of firearm owners who will never be subject to one, and they provide a realistic tool to address safety concerns which come up in firearm owning families and communities. Evidence is emerging, and the University of Colorado and the Firearm Injury Prevention Initiative is heavily involved in some of these ongoing efforts. And some of the methodology is somewhat that exists sort of historically is convoluted and in dispute, or at least something that is worthy of discussion. However, in terms of evidence, by some estimates, the number needed to treat for extreme risk protection orders to prevent one suicide death sits somewhere between 10 and 20. Which is high compared to a lot of the things that we do in medicine. Indiana saw a 7.5% absolute reduction in firearm suicide deaths in the 10 years following their ERPO enactment, which happened in 2006. They were actually one of the first. And approximately 10% of all ERPO petitions across a group of 6 states, which included Colorado, were for documented threats against at least 3 people. So roughly 1 in 10 of these petitions is for a threat of mass violence, at least according to that definition. So all of these states have them in one form or another. The list of people who can petition for them differs state to state, but law enforcement can petition in all of them. And the majority of petitions across all states come from law enforcement. The proportion comes from just over half in Maryland to almost 95% in places like California. Household members can in many states. Actually, I should go back. In Florida, which has issued the most ERPOs of any state, law enforcement are the only approved petitioners. So just have that in the back of your mind. Household members can petition in many states, including Colorado, which is because these were built to mirror, to some extent, domestic violence restraining orders. School officials can now petition in California and Colorado, and that's a list that's likely to expand. Healthcare providers can in New York, California, and Colorado. Mental health professionals can petition under certain circumstances in Colorado, Maryland, the District of Columbia, and New York. And that list of states is certain to expand as well. And then actually coworkers can petition in Hawaii. So I know that these are very small numbers, but I promise I will make it make sense. So this is data from a paper in JAMA Network Open that some of our friends and colleagues at the University of California, Davis did from a survey that they call the California Safety and Wellbeing Survey, where among other things, they asked a representative group of adults across California whether they thought that it was at least sometimes appropriate for law enforcement to petition for an ERPO in these 5 case scenarios, right? And the case scenarios were, first, a person who's experiencing an emotional crisis. The second being that the person had dementia or something like it, or that the person threatened to hurt themselves, the person threatened to hurt a specific other person, or a person threatened to hurt a group of people. So they surveyed adults across California, and what they found was that the overall statistics for how many thought it would be appropriate at least some of the time was 78% of people who responded to the survey said that it would be at least sometimes appropriate if the person had threatened a group of people, down to only 73%, which said that it would be appropriate if someone had dementia or something like it. So there's higher sort of perceived acceptability for these, at least in California, when somebody is threatening a group of people, but the margin of where it goes down to is actually not all that far down. It's still almost 3/4 who think that it's appropriate for somebody who has dementia or is experiencing a nondescript emotional crisis. So at a population level, people support these, and how we operationalize it is a different question, but who is responsible for what needs to be better sorted out, I think, and worthy of discussion. It also bears noting how ERPOs have operated in Colorado to this point, albeit all of this data existed prior to when professionals were included as approved petitioners, which only happened a few weeks ago. To get a sense of both the timeline and how each step of the process weighs on outcomes, let's look at our group's description of Colorado ERPOs in 2020, led by Leslie Barnard from the Firearm Injury Prevention Initiative and the Colorado School of Public Health. Granted that this is only data from 2020, we're updating it right now, and 2020 was a weird year for a lot of reasons, but it's the first year we had these available in Colorado, and the proportions of orders granted seems to be holding reasonably. So to describe the timeline and what you might be seeing in this table here. Once a petition is filed with a county court, so by an approved petitioner, it's reviewed by a judge or a magistrate within a few hours, and if it's granted, the respondent is served this sort of temporary order by local law enforcement, who inform them that they have 48 hours in which to dispossess themselves of any firearms they have, and they're barred from trying to purchase more. Law enforcement also serves them notice of their hearing for the full year extreme risk protection order, as the temporary order is only valid typically for 14 days. When they dispossess themselves of their firearms, they're allowed to either turn them over to law enforcement, a federally licensed firearm dealer, or to a family member or friend, so long as that person's legally able to possess firearms and that person sort of promises not to turn the guns back over to the respondent until the order is lifted or vacated. And they have to submit documentation, or they're supposed to submit documentation to that effect that would be included in their case file. The hearing itself for the full year order is overseen by a civil court judge who allows for testimony and evidence from both the petitioner and the respondent. And then in order to grant the full year order, the petitioner needs to provide clear and convincing evidence, so that's the standard to which they're held, that the respondent poses significant risk of harm to themselves or others, irrespective of whether the respondent actually has firearms or not. And so what we saw in Colorado is that just over 2/3 of petitions were granted for the emergency order, dropping to a little over half of all petitions, which end up resulting in a full year order after the hearing. The orders that were granted were much more likely to be ones that were petitioned for by law enforcement than from family members, which was interesting. And I think we could come up with some theories as to why. And then once a full year order is granted, it stays in effect for 364 days, at which point it's vacated unless a supplemental petition is made by the petitioner or somebody else, another approved petitioner. And at any point during the order, the respondent or their legal representation can petition to have it vacated or dismissed. The other thing that I want to be sure that I say here is that when at the hearing and through the entire process, Colorado built it into statute that respondents have access to legal representation that's paid for by the state. So all respondents, not petitioners, respondents have legal representation available to them that they can have at those hearings and through the process. So where we are then is a circumstance in which not only are the delineation of roles between police officer and clinicians is being blurred, but we've created a situation in which we need to consider whether police, clinicians, or a combination of the two are the most appropriate, effective, and ethically sound responses to a patient or client about whom we have serious concerns. In fact, and in keeping with the theme of bridging the sort of connecting healthcare professionals and police that I have here, while there's currently no formal policy yet regarding how the University of Colorado and our healthcare professionals should petition for or not petition for ERPOs, there are some possibilities on the table. The first is that there's likely to be no specific policy from the University of Colorado about when or when not to petition, which is consistent with the legislation itself, which is permissive rather than prescriptive. So professionals are allowed to petition, they're never required to petition. There's specific liability exemptions built in for professionals who either petition or choose not to petition in good faith. Second, there's other models used to help community members petition via law enforcement, where law enforcement provides feedback on case information and recommends whether a community person or a professional should petition or not, or in some cases might take over the petition themselves. Related to that, there's another possibility on the table that follows what Gabriel Delaney and Jake Charles, who are legal scholars and Second Amendment experts, called what's called a double filter provision, whereby professionals who let's say if I'm a licensed clinical social worker and I have concerns about a client, I may be encouraged, rather than petitioning on my own, to submit my information to somebody else, who then to law enforcement itself, I think effectively sort of putting it in their lap, so that they can figure out whether to petition or not, or to investigate further. There's ideas floating around about how all this might end up working in Colorado within the next months to years. So stay tuned on that front. So an incomplete list of the tensions at play here might include that violence prevention intervention should be considered to be on a continuum from least to most restrictive in order to preserve patient autonomy to the maximum extent possible. ERPOs logically aren't the most restrictive. That would really be things like involuntary psychiatric holds, but they do restrict civil rights in a way which is particularly meaningful to a significant segment of the population. Second, that risk assessment is pretty limited. We have very few and very incomplete tools to use in support of attempting to judge whether someone is going to enact a threat they make against themselves or anyone else. And given this imperfect set of assessment tools, we're going to make mistakes. We're going to make errors. And what they are and what their impact is should be sort of considered. And then in some clinical contexts, particularly in mental health, behavioral health care, there are countervailing concern about the therapeutic alliance. So say for social workers, psychologists, and other mental health professionals, they have to weigh concern that if they petition for an ERPO against a client, that client is going to disengage from treatment out of concern or anger at the clinician. From them and probably from other professionals in the future, incidentally, right? And the biggest predictor of treatment success in psychotherapy is that the client comes back, and you've effectively eliminated that possibility here. So the sense that the situation is both imminent and exigent becomes a highly pertinent question, and one which, again, we don't have great tools to answer. So talking specifically about the continuum and the total ecology of suicide prevention, we should understand that violence and suicide prevention exist on a continuum, and all the points at which are clinically and politically pertinent. The vast majority of this model here, though, focuses on chronic rather than episodic risk. And this serves as an excellent roadmap for societal goals to reduce violence and its burden. But the reality, particularly with suicide, is that bad outcomes are typically the result of an acute crisis. And so that's why, I want to pull in conceptually the notion that putting time and space between a person at risk and lethal means does a number of things with respect to violence prevention. First of all, it can delay the attempt. In roughly 3/4 of documented suicide attempts, the time between the decision to attempt and the act itself was less than 10 minutes. So logically, if you can make it so that people need more than 10 minutes to get to a firearm, the acute phase of the crisis may pass, or they may come into contact with someone who can intervene. The second is that most people don't substitute means, and firearms are a highly lethal mean of violence, both in suicide and against others. And if they do switch so people don't tend to, if you remove access to firearms, they don't tend to do something else in their suicide attempts. But if they do, they're likely to switch to a method which is less lethal, which is less likely to result in death. And if someone replaces a gun with an overdose attempt, they're far more likely to live, right? But again, people more typically give up on if their preferred method is unavailable, or they delay long enough that sort of a different sense takes hold. The take-home message of this is that any method which increases the time and effort necessary for a person who's in crisis to access a firearm has an excellent probability of preventing suicide or other violence. So going back to risk assessment and the challenges that we have here. At a basic level, the actual assessment of human threats is really challenging. We value sensitivity over specificity because while false positives lead to limiting individuals' rights or treating them in a more restrictive environment that is necessary, false negatives could mean that someone is violently victimized or harms others. That's if you're doing an absolute gold standard assessment, right? And so I have this table here from Gandhi in academic medicine, of all of the sort of elements that would be included in a, again, gold standard threat assessment process. But all of these elements don't really accord with the realities of most outpatient healthcare workflows, which leads us to some, competing sensibilities about what what we're supposed to do when we have a sense about a patient, or a patient is expressing they're threatening something, or we have a sensibility about them, or both, right? We have the intellectual knowledge about threats in the context of what our intuition is telling us, right? So then we can kind of go back. And this is Gavin Knoepke, who is a security and threat assessment expert whose company designs personal security and assessment and response protocols for elected officials, the Supreme Court, business leaders, and celebrities. There's a fun little anecdote about him that he was briefly married to Alanis Morissette in the 1990s because she hired his company to develop a safety protocol for her when she was at the peak of her fame. They fell in love, they got married, they got divorced a few years later. But anyway, in his New York Times bestselling book, The Gift of Fear, he's quoted as saying that threats betray the speaker by proving that he has failed to influence events in any other way. Most often they represent desperation, not intention, right? So we intuitively know that most threats aren't going to be acted upon, and that might cause us to have concern about reacting to them, right? But that runs into another reality nicely laid out by fellow threat assessment expert, the timing that got messed up, but fellow threat assessment expert Gavin Knoepke, who in his New York Times bestseller, The Gift of Fear, said, intuition is always right in at least two important ways. It's always in response to something, and it always has your best interest at heart. So where we are is that highly trained health and human service professionals we've been in this bind for a long time, not just with ERPOs, but with involuntary psychiatric commitments, things like that. Where not only do we have the same intuition that any human being has, but we're additionally burdened by years of training and credentialing that was supposed to make us better at this, but doesn't necessarily do so. The knowledge that the person came to you for help in one way or another, and the ethical obligation to help them to the best of your ability. We also have a scope of practice that includes temporarily restricting patient civil rights, including psychiatric holds, and experiencing and practicing discretion in doing those things. And we also have a job and a license that we'd probably prefer to keep. So we have all of these things that are weighing on whether petitioning for one of these restrictions against a patient or a client of ours is the right thing to do. So leaving aside the fact that lower level interventions that should come earlier for a second, I'm going to come back to that. Let's play out the string of likely incomes if a patient or client presents to you with risk that you think might warrant an ERPO. Your goal, by the way, of course, as a healthcare provider, is to prevent violence, whether it's self-directed, other-directed, or both. So you can choose whether to petition or not, which would leave us a 2x2 matrix. However, even if you do petition, it can get denied, which gives us an additional 2 outcomes. And within this set of 6 outcomes, there's really only 2 within the matrix that are a match, right? So you have this match in the blue where you didn't file for an ERPO and the patient does not enact any violence subsequent to that. Or you have in the red where you did file for an ERPO, it got granted, and the person does enact violence. If in the red sense, that's a match, it's an unfortunate situation, but it's a match where hopefully you limited the lethality of the means that the person can use to enact violence against themselves or somebody else. But in the blue one, you choose not to petition and there is no violence, and you've probably done some damage to the therapeutic relationship like I was talking about before, and you might have given the person reason to hide risk in future interactions with healthcare professionals. There's another possibility where there's this type 3 error in the purple box here, where you petition for an ERPO, which was denied, but the person doesn't enact violence. So that's sort of a right outcome for the wrong reason, and the therapeutic relationship is still at risk because they know that you petitioned against them. There's also a high potential for type 1 error here in the yellow box, where you get an ERPO granted, but the person does not enact violence. That's probably the most common outcome likely in here, right? And this might be because the ERPO prevented the violence in one way or another, right? That may entirely be possible, but that would absolutely be a success, but is also nearly impossible to directly attribute. So in this case, the person has had their rights abridged in the interest of safety, which is good, but may also have deep and perhaps counterintuitive meaning for them. There are other type 2 errors, of course, in which an ERPO isn't pursued or is pursued but not granted, and the impact of these failures is a potential loss of life. And that's the counterweight, right? Like that's what's weighing on the other side of this equation, is that we really don't want the green or yellow boxes in which somebody is enacting violence after not using the tools to the maximum effect possible. So revisiting this, so there are other options along the path, other things that we should be considering when working with patients or clients who are at risk. Lethal means counseling, which I'll talk about a bit here, connection to other services and support, and police welfare checks. Police welfare checks have been the tool sort of choice for a long time, particularly among behavioral health providers who may not have been comfortable or may not have felt that it was appropriate to enact a psychiatric hold against a client, but who nevertheless were concerned about them and wanted to sort of call extra eyes into the situation, and did so with police. And that's sort of a little bit of what the double filter provision method of petitioning for ERPOs seeks to do. It seeks to sort of mirror that process to some extent by specifically, again, sort of saying that petitioning for these kinds of orders is more appropriate within the context of law enforcement than it is for other professionals or other community members. But coming back to counseling on firearm safety, for those of us who work directly with clients and families, I just urge everyone to think about firearms as a form of cultural competence. And this is something that Dr. Betts and Garen Wintemute, who's at UC Davis, have been talking about for years. This was an editorial in JAMA calling for firearm ownership to be understood as a culture, which absolutely makes sense when we expand our definition of culture beyond the kinds of things which appear on the census. So I always have to do this because again, what I said earlier is that the general training around counseling for suicide prevention or other violence prevention and professional training programs is not wonderful unless there's a few sort of specific people around. And so this is an opportunity to try to broaden that reach a little bit. So counseling in the context of threats, and specifically suicide threats, using clear, unambiguous language, inviting more conversation, letting the client or patient know that you can handle it, right? So euphemisms convey our inherent skittishness in talking about suicide or death, and displaying that discomfort, real as it may be, can lead clients to editing, downplaying, or otherwise in an effort to preserve our feelings, right? Which isn't the goal, right? We want to be the helpers here, and we want to assure them that whatever it is that they're bringing into the room, that we can handle it, and there's something that we can do about it. So saying things like, are you thinking about killing yourself? Not hurting yourself, killing yourself. I'm glad that you told me about your suicidal thoughts and what's going on that makes this a situation for you, that makes you want to die. And then ask directly if they have access to a gun, even if that's not part of the plan. A lot of the mental health professions training programs sort of emphasize this stepwise approach to suicide assessment, where it's like, are they thinking about it? Do they have a plan? Do they have means? Are they gathering them, etc.? And what I'm advocating for here is like, that's not a terrible way to approach it. But the thing to say is, do you have access to a gun, irrespective of what plan they had, or even if they didn't have a plan at all? And then also connect, don't contract. Oh, I went way off there. Connect, don't contract, and suicide risk contracts used to be a big thing. I hope that they're a little bit less common now. And they're generally not indicated, as clients are more likely to see them as legal coverage for the therapist rather than attempting to help the client stay safe. And plus, they're plain patronizing, and they affect the therapeutic alliance as well. It's better to affirmatively give them access to resources they can use at any point, in addition to whatever services or referrals you're going to provide. The national hotline is now available by calling 988 in English and Spanish, and with other languages available, and internal transfers to veteran-specific lines. Some clients prefer to talk to someone who either specializes in their population area or would rather talk to a warm line where crisis intervention isn't the primary goal, but more general support. I want to give a quick hat tip to the citation at the bottom. So Stacy Friedenthal is a professor of social work at the University of Denver, and one of the nation's leading experts in working clinically with people at risk of suicide. And I highly recommend helping the suicidal person for healthcare providers. So talking about lethal means, though, specifically, is that when a person does have access to firearms, there are a few options with respect to reducing risk, which sort of boil down to voluntarily changing their access to them. Remember, we're working in the voluntary frame of things now, before we get to the involuntary things like ERPOs and other things. The voluntary changing of access, either by storing them inside their home but inaccessible to the person at risk, or moving them temporarily outside their home to be stored with others. Considering these options can be a bit of a process, not the least of which has to do with the reasons for owning a firearm in the first place. So you want to be able to be sensitive to that. But optimally, you engage someone else in the client's life to help facilitate storage by physically moving the firearms outside of their house. But you also need to be aware that others may not be, that the client may not be comfortable in using others or feel as if others can be safe in handling firearms either. So in their home, in general, firearms, whether somebody is in crisis or not, should be stored locked and separate. It should be locked and unloaded and separate from ammunition. And so in these cases, the most basic adjustment, if people are not willing to move their firearms outside of their house, would be changing the storage situation such that the person at risk no longer has access to the safe or locking mechanism or whatever. The sturdier the locking device, the better. But really the goal is that the person who maintains access to that is not the person who's at risk, whether that's the key, whether that's the combination, the fingerprint that opens the lock, whatever. There's also other options like disassembly, which again isn't for everyone, but it's possible with many firearms to remove a critical component without constituting a legal transfer of a firearm, which can be a sticking point, but it still renders it unable to shoot until it's put back together. And then out of home options, so storing with friends and family, which is probably the most common approach. Again, clients may not want to involve others in their situation for a variety of reasons. Another thing to be aware of is that some states like Colorado have rules about who a firearm can be transferred to, for how long, and whether or not a background check is necessary to return it or to transfer it to the person. And then storing with a business or law enforcement is always a possibility as well. I know what you might be thinking as clinicians who've been out in the world, that you'll put ideas in their head that it's illegal to talk to clients about guns. I don't know anything about guns and I'm going to be out of my depth, or that guns are so sort of fraught within our society and that you'll damage the therapeutic alliance by bringing them up. And much of these concerns actually boil down again to the cultural divide between those in the firearms community and those who aren't, and a lot of practitioners belonging to the community of those who aren't, right? So we've actually done, some research on this, and I have to, shout out, this was my very first firearms related project. But the thing that we want to emphasize is that, yes, you can talk to clients about firearms access. Yes, even if you're in Florida, and particularly when the clinical situation is such that you are concerned about safety. You are always within your rights to do so. There's legal arguments and reasons why that is the case, but that is where things stand right now. But that's separate from the question of what clients and patients think about it. So, check out this loaded questions, which again is one of my absolute favorite projects and my first foray into firearms violence research. So you can see up at the top left corner here. So that was Dr. Betts, Dr. Wintemute, and Dr. Megan Ranney from Brown, who's moving to Yale. Published an article called Yes, You Can in Annals of Internal Medicine, which was like a clarifying call for healthcare providers about, yes, you can talk to patients about firearms access. That paper got some attention from lay press, including newspapers and sites that have comment sections appearing between their articles online. So we did a descriptive content analysis of the descriptions of these anonymous internet commenters when talking about how this paper from Annals had been interpreted by MSNBC, Medline, Fox News, a few other places. It's the furthest thing in the world from generalizable research, but I do want to say that it gets at extreme viewpoints in a way that few other forms of research can logically do. And I'm not going to go through all of our findings here, but there was all the bluster and bravado that you would expect of internet commenters, but there were a few themes that emerged as situations in which even the most vociferous opponents of firearm safety conversations with healthcare professionals were seen as appropriate or even recommended. One of them was crisis or emergency intervention. So this was a quote from a person who generally disagreed with the concept of healthcare professionals talking to patients about firearms, but they were then quoted as saying, crisis or emergency intervention, absolutely yes, ask and intervene. And then, but the flip side of that again is this nagging thought that many providers don't have the requisite knowledge about guns to be able to effectively counsel people. And this view was expressed within, you know, this group of individuals as well, with healthcare providers seen as generally outside the community and therefore lacking in the knowledge necessary to be helpful to supposedly more knowledgeable firearm owners. This might be true in many circumstances, especially for the more engaged firearm owner, somebody who's had firearms for a long time, but probably much less so for new casual, you know, gun on the bedside table type firearm owners. Which leads us back to where we started, and I'm glad that we left some time. I have some other things that I can talk about if we want to. But with red flag laws sort of hanging like a cloud over conversations between patients and healthcare professionals, when in reality, they're just a tool. They're something for the back pocket when nothing else is working. They have a lot of impact, both sort of actual and sort of theoretical, but they are at their core confrontational and carry risk to any professional's ability to work in the future with that patient. So the sort of final word on red flag laws, I think, is that they can be effective and are politically viable. So professionals who choose to petition in good faith are on solid ground in doing so. And from a professional ethics and responsibility standpoint, they should probably be something of a last resort when there's a clear and imminent crisis or when there are other less restrictive and confrontational methods have failed. In a lot of cases, especially where a patient's risk is more chronic, methods which encourage patient autonomy and connection to supportive services and trusted others are preferred, especially when combined with voluntary limitations on access to firearms. Nothing that I do or that anybody does is just me or representative of just my work. There's a huge group of people. I named some of them earlier. I want to call out a bunch of specific others, both at the University of Colorado, in other places in Colorado government, and then fellow academics from around the country. So with that, I think I'll open up for questions, and then I also have some other tools and materials and hopefully they will address some questions as well.
Thank you so much, Chris. We have 2 questions in the chat. The first one, 3, you answered the first one about, is it ever required reporting, like in child abuse? And you answered it's always permissive, never required.
In Colorado, at least, that is not true.
Okay.
In New York, that's not true, but in Colorado, that is true.
Good. Thank you.
Mm.
So are there any differences between the people who self-harm and the people who are at risk of harming others?
In terms of their
Any differences? Profile, mental health?
So I think that the group of people who are at risk to themselves is inherently just much larger than the group of people who are at risk to others. That's not to say that people who harm others are is a small group. That's unfortunately not true, but the group of people who are at risk to themselves is much larger. And again, that is to say that I think that it's a reasonable approach in most circumstances, especially when somebody is not expressing direct threats to somebody else. Their first sort of set of clinical attention is on threat of suicide and other sort of self-directed violence. Now, whether they differ demographically, I think that I don't actually have a great answer for that. But I think that again, the clinical attention should be on self-directed risk. But then because there are also other tools available when an individual is making threats directed against somebody else.
And that's leads into the second question about connect the dots between optional reporting and duty to warn, for example.
So, connecting the dots. So I think you're actually talking about 2 distinct processes, right? And so, in a case where a professional is confronted with a threat of violence against somebody else, then where they have a duty to warn. None of this has changed duty to warn, by the way. It doesn't affect it in the slightest. So we still have the same responsibilities we had before. about duty to warn, duty to protect, Tarasoff style reporting kinds of things, right? Where you have a duty to inform an individual if they are the target of a threat, or an institution if it can be identified, etc. Now, whether that then becomes that you pursue this other restraining order, I think has a number of different calculuses within the beneficence and non-maleficence calculus that you would have to weigh, as far as whether you were going to be the person who was going to pursue an order against a patient or client, or whether you were going to pursue other types of action. And this is all assuming that you've done other things that are voluntary or lower restrictive kind of activities. But they could also include the things that we've always been able to do, such as M1 holds, if that's an appropriate thing, or police welfare checks, if that's an appropriate intervention, or referrals to other types of treatment or service.
So to bring it closer to home, if a patient threatens violence against staff in a clinical setting, and unfortunately that's not so rare these days, would that be an acceptable situation to consider petitioning, or that would the patient have to specifically threaten gun violence?
That's a great question. They don't have to, in no circumstance does the person have to specifically threaten gun violence for someone to pursue an IRPO, right? In fact, and in California, their statistics are a little bit different than what we saw in Colorado, but the legislation is similar in this respect. You don't have to illustrate that the person has access to a firearm in order to petition for an order. Now, how that gets treated at the court varies county by county, but if you felt that it was an appropriate time to petition in order to preserve safety, you absolutely could do so. There's a separate question about whether threatening staff would be an appropriate circumstance under which to petition for an IRPO. And I think that you would treat it like that person was threatening anybody else. You consider their situation, their history, the veracity of the statement that they made, all of those things, just like if they were threatening someone else in their personal life.
So the same person that asked about the differences between self-harm and harming others admitted bias against those harming others. More effort should be expended to prevent this harming others, but really challenging. Are there no differences in how we should prevent harming others?
Well, I don't know that I'm totally understanding the question, but I think that it is fair to say that that it is easier to wrap our minds around protecting somebody else because there's a good guy, bad guy distinction being made there, right? Where the bad guy is somebody who's going to enact violence against someone else. Whereas a good person within this sort of frame and context, I'm not saying that I agree with this, but that we also think that it is possible that a good person could be distressed, tormented, not able to keep themselves safe. All that I'm saying is that is actually the more common type of violence, and other directed violence often has suicide risk associated with it. So that I don't know which other distinction to make.
Yeah, I've heard people say when we're grieving, lamenting the mass shootings, and then the shooter shoots himself or herself. Why did you just not take yourself out? And why did you have to kill other people? I've heard that sentiment to admit that there is this feeling of why did you have to murder people if you're just going to kill yourself? So there is, I think you're right, Chris, this is more egregious. It's bad that you're killing yourself, but this is even more egregious. Can we, and why do we emphasize suicide over the prevention? I understand.
Oh, I hope I don't want to be misunderstood that I'm emphasizing suicide prevention over prevention of other violence. I'm just saying it's the one that you're more commonly going to encounter.
Yeah. And are you suggesting that providers should always ask patients about whether or not they have access to a gun as part of the standard assessment, cultural competence, that kind of the safety screen?
I think that, so in terms of talking to patients about it, I think what you should understand is that you are always on legal ground to ask if you feel like it's pertinent. I am, we're always sort of cognizant of the fact that introducing that to the conversation feels touchy in a way that we might not be comfortable with. One of the other findings from the Loaded Questions project, and that we found in other places too, is that people generally aren't put off by talking about firearms as a source of risk if you provide education about it without asking, or also if you couch firearms within other sources of risk. So for example, and an anecdote that I like from other talks that I've given is I busted my kid's pediatrician once on this, that that they were going through their normal, do you wear helmets, do you wear seat belts, are you in a child seat, how have you locked up chemicals in the in the garage, or cleaners in the kitchen, etc. And then didn't ask about firearms. And because we know that if you couch within, let's talk about bicycle helmets and let's talk about pool safety, and then let's also talk about firearms and power tools in the house, that people aren't generally put off by that, and they see that as an appropriate use of resources. Now, I think, like, when you say that this is about people in a general non-emergent circumstance, those are supported, and there's reasons to do it that way. When you're talking about crisis assessment, or where there's a reason to think that someone's access to firearms might be less safe than it would be under normal circumstances, then you are absolutely on solid ground to do so.
So you're getting a shout out from Jamie at Children's, that we ask all of our families in children's primary care settings that exact question, and they have a supply of gun locking devices to support. It makes sense to normalize this conversation.
It makes sense to normalize, and there's laws now around safe storage where parents are responsible for storing firearms in the safest possible manner within their house. And if giving them the little gun locks is a reminder at the very least that that's a responsibility of gun ownership, then that's a victory in and of itself.
Unless I misunderstood, that your involvement with law enforcement and education with law enforcement is what kind of education is needed, and what are you researching? Because you can't watch the news without a police shooting. So police shootings are part of the context of violence, and who's willing to see culturally, who's willing to see police in a saving role rather than a threatening role. Can you speak to the education that you're offering to law enforcement?
So it's an excellent point that there is debate about the appropriate use of ERPOs, especially within communities of color. And what I will say is that there has not been an accusation of inappropriate use among communities in Colorado, because it largely, I think the conversation has more been that these have been underutilized across the board in Colorado. Now, in other states, there's some data to suggest, and I was a co-author on this, that the case circumstances surrounding restraining orders where the respondent was white differed substantially from ones in which the respondent was Black. There weren't differences seen in other racial or ethnic groups, but there's reason to think these things through. And the role of law enforcement within it, I think, is always sort of up for debate, because there's a fraught relationship with law enforcement and a number of communities. But At the same time, our educational efforts are specific to Colorado and to Colorado's sort of legislation and the legislative intent is to simplify the sort of understanding of what it is, the process that it goes through, the due process protections that are in place for respondents, as well as illustrating, real and observed levels of community support for these in specific high risk kinds of circumstances.
Yeah. What do you think, what do you see as the impact of the Club Q people suing law enforcement, the government, for not taking away the firearm?
Mm-hmm. So another disclosure here is that I'm a Colorado Springs native. There's a community level impact to things like that, which is difficult to sort of disentangle yourself from. Also, the community is only so big there, so there's people who know everybody. And what I think is, and we haven't seen what exactly will happen. I think that lawsuit has the potential to be really instructive and influence the way in which law enforcement across Colorado and perhaps in other parts of the country might treat these orders. Now, Colorado is a little bit of an interesting circumstance because we had so many counties that in the time between when the Deputy Zachary Parrish Violence Prevention Act, which created the ERPO system, was voted upon, and in the time between that and when ERPOs were first available in January of 2020, a number of these counties declared themselves Second Amendment sanctuaries, which is a political proclamation, but doesn't actually have any impact on whether someone could petition for or grant an ERPO in those counties. And what's happened is, while we've seen a lower rate, like population-based rate of petitions in those counties, it hasn't been zero. And so there are circumstances under which, even in those counties, they've seen situations where an ERPO was seen to be an appropriate intervention to try to promote safety of both the individual and the community. So please.
Two final questions. What if your patient is a law enforcement officer and the ERPO would affect their job? First question. And the other is looking for language and advice when the family member pushes back, thinking that it's going to reduce my safety, my ability to defend myself, locking up my firearm and keeping the ammunition separate.
Yeah. So in the first question, when somebody is in a profession where firearms are central to their duty, whether that's law enforcement, whether that's the military, whether that's private security, whether that's whatever, I think then, first of all, we should always be talking about voluntary methods first, and then the voluntary methods just become sort of more complicated. And they're storing, personal use firearms outside the home may be one level of the intervention, but again, like you said, that may introduce some challenges in their professional life. And this is where I'll give a shout out to my former, community in the employee assistance profession, where law enforcement, generally speaking, have EAPs. They have internal EAPs. They have programs with both peers and professionals, which are adept and receive training in managing this, duty assignments and things like that, while somebody is actively in treatment or getting support, can be critical to helping that person maintain their income, maintain their sense of importance, maintain their role within their family, while also getting the support that they need while limiting their access to lethal means. And then the second question was, I'm sorry.
What do you say to what should a clinician say in response to a family member that says, if I lock up my firearm and separate the ammunition, I'm at risk, I can't defend myself?
This is very central. This is very difficult, right? So for most people in the United States, including in Colorado, the primary reason that they own a firearm is for personal protection. If this was a family that had hunting rifles that they only break out once or twice a year, then locking them away or taking them somewhere outside the house might be not seen as that big of an encumbrance. But I think then, this is just an active conversation where you're engaging with the people about, okay, so what we would like to do is limit access to the person at risk. Is it possible that someone else in the home maintains access to the firearms, but not them, right? So if it's in a safe or has some sort of locking device on it, then the key goes to the partner rather than the person who's there themselves, right? So things like that. It's a problem-solving situation, and of course, if the primary reason for firearm ownership is personal protection, it just gets a little bit more complicated.
We're at time. Thank you so much, Julie.
Well, yeah, Dr. Knoepke, I really want to thank you very much for talking with us about these issues and about the ethical dimensions, which really are, you've even named all 4 principles in this time that have many dimensions to them in and of themselves: justice and autonomy, beneficence, non-maleficence, and all kinds of implications of those. Thank you very, very much for your work and for helping us understand that even further in a public health sense. Appreciate it. So everyone, thank you very much for attending, and we'll see you in September.
Thanks for inviting me. It's been an honor.
Thank you.
Take care.